Hello, I'm Dr. Benjamin Levy. I'm an associate professor at Johns Hopkins School of Medicine and the clinical director for the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C. So it's often a very nuanced and difficult decision as to what to do for a patient with advanced stage lung cancer harboring an EGFR mutation at the time that there's disease progression. And I think the first thing that you need to define is the progression. And progression in this setting is heterogeneous. There's oftentimes just slow progression where patients can remain on the EGFR-directed therapy. There's oftentimes oligoprogression where there is just one area that's growing where all other sites are stable. And again, an opportunity to potentially radiate or consider surgery for that local area and continue on the EGFR TKI, specifically osimertinib in most circumstances. When there is systemic progression and there's the need for a therapeutic switch, I do think there's a lot of different data sets out there and things to consider. I would say that the standard for patients that are EGFR positive who've developed disease progression on osimertinib, the standard would be chemotherapy. And generally, the standard that we use is carboplatin and pemetrexed. Now, there are questions, however, whether you can add additional agents to platinum pemetrexed and improve outcomes in this setting. And we just don't have great data on this. We don't have carboplatin pemetrexed bevacizumab versus carboplatin pemetrexed for this. But we do have emerging data sets that may help define particular combination strategies. So one of the questions that comes up in this setting is, what's the role of checkpoint inhibitors or anti-PD-1 drugs? Well, we have a recent press release from the Orient 31 trial. This was a trial evaluating cisplatin pemetrexed sintilimab, which is an anti-PD-1 drug, versus cisplatin pemetrexed sintilimab plus a bevacizumab biosimilar, asking the question, does the addition of bevacizumab, the biosimilar bevacizumab, does the addition of that agent to platinum pemetrexed anti-PD-1 with sintilimab improve outcome? And what we've seen is, at least in a press release, an improvement in progression-free survival with the addition of a biosimilar bevacizumab to a backbone of cisplatin pemetrexed sintilimab. There are other questions that are being answered as well. There's Keynote 789. This is a trial looking at carboplatin pemetrexed versus carboplatin pemetrexed pembrolizumab post osimertinib at the time of progression. So very similar setting, asking the question in this case, does the addition of pembrolizumab to platinum pemetrexed improve outcome compared to platinum pemetrexed alone for patients that are EGFR positive who have had disease progression on osimertinib? Finally, another trial that I'm participating in and help leading is looking again at the quad regimen of carboplatin pemetrexed bevacizumab and atezolizumab. And in this time asking the question, does the addition of atezolizumab add anything to carboplatin pemetrexed bevacizumab backbone? So a little different question than the Orient 31. This is a trial for patients that are EGFR positive who develop disease progression, randomized in a 2-to-1 fashion to either carboplatin pemetrexed bevacizumab versus carboplatin pemetrexed bevacizumab with the addition of atezolizumab. So there's a lot of outstanding questions here, and I would say that hopefully in the next year or so, we'll have definitive answers. I think you can't go wrong when there's time for a therapeutic switch to deliver carboplatin pemetrexed, but whether bevacizumab or anti-PD-1 makes a difference, we'll find out hopefully very soon.